Hello, everyone. I hope you're having a wonderful day. I would like to thank you for joining us, and I'll wait just a minute so a few people can jump on. I have a very, very exciting guest for you today, but this is our first Instagram Live. We're usually on another platform, and so I wanted to take a moment for those of our followers who are curious about EO2. We're glad you're here. Thanks for the follow, and please feel free to share. What EO2 is it is a startup company from San Antonio, and we have a small portable oxygen generator. It's silent, and this is for oxygen generation that penetrates down to the wound bed through a proprietary dressing, and it provides not only full closure, but also pain relief for your patients. So we have tons of literature that has been published already. If you haven't had a chance, check us out at eo2.com. And we do have the highest level of research coming as well within the next quarter, which we are very excited about. It's a meta-analysis, and we can't wait to see what the experts are saying. So stay tuned for that. And again, all of that research is available over at eo2.com. But this month on social media, we wanted to go back to the basics. We realized that a lot of people are coming to us fresh and new, and so we wanted to talk a little bit about continuous diffusion of oxygen with one of our longest running advocates, who is Dr. Mark Couture, and we are going to bring him on board. If you are watching us, wave, say hello, and there he is, Dr. Mark Couture. Thanks for joining us.
Hi, everyone.
So, Dr. Couture, our followers, Dr. Couture, why don't you take an opportunity to tell them a little bit about yourself and your experience?
Absolutely. So I've been with the Temple VA for a little bit over 11 years now, about 5 years of private practice before that. Heavily involved in wound care and limb salvage at our VA. I've been fortunate enough to specialize in limb salvage and wound care for lower extremities. I've had experience with the TransQ/Oxygenate device for, I believe, over 8 years now, and in fact performed so well that decided to do a research project on it, and we got it published. So I continue to use it in daily practice. It's something that we can certainly answer your questions. I know that Kate has a battery of questions for me that she wants to ask.
I do.
So I'll be happy to answer that. But very familiar with the device, and very successful as far as wound healing, not just improving a wound, but actually wound healing.
That's a very good point. Very good point. And you're right, I do have a whole battery of questions for you, Dr. Couture.
Okay.
But with that being said, if you are watching and you've got a question, please feel free to drop it down into the comments as well. So why don't you give us kind of your overall experience with CDO, including kind of what wound types you see that are appropriate?
Absolutely. So when I first started using CDO, I was a little bit skeptical because I tried some topical oxygen therapies prior to that, and they just did not work. And CDO, is very important to know, is a very different technology from topical oxygen. It's something where you have to use it basically to see the benefits. And what I've done personally from the start is when I've used it is I will place it on a patient either as a solo therapy or sometimes with even a biologic, and then keep the dressing on for a week. And then they come back in a week in which the dressing is changed, the wound is assessed and debrided, and then reapplied. So I've always done it on a weekly basis.
Okay.
As far as when to use it, I've used it on a multitude of ulcers, whether it's been diabetic foot ulcers, venous stasis ulcerations. Usually, you want to go through conservative therapy for at least 4 weeks to see if your conservative care will have an effect on your wounds improving. But
right.
If you're not at least 50% smaller by 4 weeks, in some wounds, you may want to consider advanced therapy. And I do consider oxygenate to be an advanced therapy. So whether I use it as a solo treatment or in conjunction with a biologic, everything is kept on for a week. And The initial concern sometimes is that when you first see a wound back for the first or second week is that there may be some increased maceration around the peri-wound area.
Mm-hmm.
And not to be alarmed by that. That's just the environment regulating itself.
Right.
And that's not going to continue. So I've never had to alter or stop my therapy due to maceration concerns. I do believe that if there's an edema issue, that has to be addressed
Yeah.
with what the etiology is. Whether it's a congestive heart failure, venous stasis. But you can use it with a compression wrap too. I've certainly used it with compression wraps
Yeah.
for some VLUs.
Absolutely. And so you bring up a good point. So once the oxygen starts to penetrate into the tissues that maybe have been hypoxic for a while, there is this wound reaction of increased exudate. And we do find that that's one of those things that you just need to get comfortable with. And I think with some of the other therapies out there, there's been no increased exudate is bad. Whereas with this, that's exactly what we expect. So it's just dealing with that and managing it.
Right. I do think the other important point is that, a lot of times, same thing with a wound vac. When you take off a wound vac dressing, sometimes you may get an odor, with your wound, and that's odor is not necessarily a sign of infection. But if you keep a dressing on for an extended period of time, especially up to a week, you may get an odor that may put someone on the alert that it could be an infection. But if you assess clinically, it's just the odor from some of that drainage sitting on there, and as long as you're not getting maceration that's going to damage the peri-wound tissue, then you're okay. But that odor is not does not mean that the wound is infected automatically.
Right. No, that's a good point. Good point. So how do you know a wound is ready for oxygening? What are kind of your criteria that you look for before placing the device?
Well, I think, going through your basic exam to check on vascularity for a patient, assessing their A1C, their compliance with offloading, because there's a lot of different wounds in the lower extremity that you deal with, and not everything is treated the same. You have to treat it from an individual patient standpoint. Are they still smoking? Do they need a vascular evaluation? Do they need offloading that you even need to change during the course of treatment, where maybe a post-op shoe is not sufficient, where you have to go to a total contact cast? But with all the different offloading devices that there are, you can use Oxygenie with any one of them. Sometimes I'll do a window in a total contact cast. You can run the tube out of it, so it's not resting against the skin. You can also do with a compression wrap, as we mentioned before, where you can also make a window out of there so that it's not being pressed into the skin to create maybe a new pressure issue.
Yeah.
So there are ways that you can do it, and we're fortunate at our facility to have prosthetics up on the floor with us where we can send them over for a boot or a shoe right away potentially. But offloading and looking at what else you're doing for the patient is important. As far as the wound itself, I mean, you certainly want to have something that has some kind of vascularity to do it. Although if a patient is optimized from a lower extremity vascular standpoint, and if they've got questionable circulation, I think that oxygening is a perfect treatment, because if vascular cannot provide anything else for you for that patient, and the patient's stuck with what they got, oxygen is obviously something that the arterial system carries to a wound, and if they're lacking, then Oxygenie provides not only a continuous source of oxygen, but consistent, right? So it's very different from hyperbarics, in which you get a very big spike for a couple hours for a day, but then it goes back down the baseline the next 22 hours.
Right. No, and that's an excellent point. I know a lot of other surgeons like yourself either use it as a bridge, or, when they can't be revascularized, they utilize the Oxygenie for that. So that's an excellent point.
Right. I think too, if you're using biologics, you may want to try the biologic first, but I think that these days you can consider Oxygenie as a substitute for a biologic in essence, where if you're going to consider advanced therapy, you could try the Oxygenie therapy by itself.
Yeah.
And forego the biologic. I only do dual therapy when I see it's indicated. So let's say that you're doing a biologic, after several applications, your progress is minimal, and maybe you need to kickstart it.
Yeah.
You add the Oxygenie to it to try to kickstart it, and we show that in the study that it provides a benefit. But using it as a solo treatment is certainly something that you can do.
Perfect. Yeah. And that study is available on our website under publications, if you're looking for that. So, and we can definitely, when we post this to other sites, we'll make sure that we put a link to it underneath. So curious, so you've talked a lot about the therapy, so a good debridement, managing the whole patient, not just the hole in the patient. Tell me about your patients' reactions. Generally, you're dealing with, elderly patients in your practice. What are their experience coming in a week later with this device? How do they react?
Well, very interesting because they first think that it's not working because they can't hear it, and it's
Right.
a silent device, and so sometimes patients are skeptical. So, for example, I had a patient that actually put the oxygen tube in some water to see if it was blowing bubbles, and so we had to tell that patient that that's not how it works. So it's not that it has to make noise to know that it's working. It doesn't have to blow air. But I think that patients respect it because they're able to be, mobile with it, where, versus going to a hyperbaric oxygen treatment,
Yeah.
Once every day, 5 days a week, that could be very time consuming and also very costly for the patient with transportation. But
Yeah.
they have a device that they can take with them, and although you want them to offload, they're able to, provide the therapy at home, right? You don't have to go to a medical office to get the treatment. And, some of the patients, I can tell you, when I tell them it's the size of a Walkman, think they're getting a Walkman. So it doesn't play music, but it does provide oxygen on a consistent basis.
There you go. There you go. And they'll get the Walkman reference for sure.
Right.
Very good. So any particular patient stories stick out for you, Dr. Couture?
I think, sharing that one with the blowing bubbles and then he took it off was one story. But on the more positive side, there was a patient in particular that I did early on because when I did the study, I gave EO2 some of my worst patients, wounds that weren't healing,
Yeah.
wounds that, they were considering below knee or above knee amputations. And so you're trying to use something as a last ditch effort. You've, thrown other modalities at it. So I had one patient in particular who was actually told that he needed a below knee amputation by another doctor. Yet I said that let's try this amputation level because we had him assessed from a vascular standpoint. Although it was iffy, we gave it a go, and he knew that with his tissue loss, we wouldn't be able to close the wound, right?
Right.
But what we did is we did tissue applications in combination with the TransQ at that time, now Oxygenie device. And through about 12 weeks of consistent treatment, we got his midfoot amputation to heal up, and he basically was left with an open midfoot amputation because all the tissue loss. There really wasn't a flap to do. And, he healed all the way where he granulated in, and we were able to get him into a device through prosthetics where he was able to get around and be mobile again. Basically a patient that was going to lose his leg and be forced to be less mobile. And of course, a lot of the concerns with getting a leg amputation is that your cardiovascular status goes downhill after that. A lot of times you're less mobile, whether or not you get a prosthesis or not. So we're able to keep this patient mobile and get him healed from basically a guillotine amputation of the forefoot. And it was really something to see that, we healed him all the way up from start to finish. And that case study is actually one of the ones that I used a lot when, giving talks because it showed just how effective consistent therapy can be. If you bring your patients in weekly, to every 2 weeks, I think that they have the best chance to heal.
Nice. Excellent. Thanks. So I know that there are a lot of new podiatrists on Instagram that are watching us, and a lot of docs are new to continuous diffusion of oxygen. What would be your advice when they're trying Oxygenie for the first time?
So I think, encountering wound care, there's a lot of physicians who may be hesitant to use something. And I think that differentiating Oxygenie from topical oxygen treatment is a big thing.
Yeah.
Because if you're up on literature, you know that the topical oxygen therapies that are out there maybe don't show the best support for wound healing. And whether you've had your own personal experience with it or not, but Oxygenie is a completely different technology. Continuous diffusion of oxygen, and I think just using it from the start, giving it a trial. I mean, you basically are just placing a bandage on a patient post debridement that stays intact for a week, and then you just see the results week to week. So it's just a matter of trying it for yourself. If you have a difficult wound that you can't heal, try putting it on and see if it works. And that's what I did. That's what made me a believer in it, because I gave you guys some very difficult wounds. And not everything's going to heal, but
Right.
we showed in that study that even with tough wounds, we still had over a 60% healing rate.
Yeah.
And and that's been consistent to this day. I expect 60 to 70% of those wounds that I use that with to get better.
Yeah. No, that's excellent. And you bring up a point as well. The predicate devices before this smart, rigorous, continuous diffusion of oxygen, a lot of those earlier oxygen delivery devices didn't have the safeguards in place to make sure oxygen was flowing, the capillaries weren't being closed, that everything was working properly. So a
Right.
lot of the earlier devices did definitely have some issues with them for sure.
Right, and I think that making people aware that the dressing does not have to be airtight. It's not a vacuum seal like a wound vac.
Yeah.
The fact that with some of the topical devices, you had a tube. You had to worry: is this tube going to stay where the wound is, or is it going to move around? Is it going to pull out? But because of the way that the dressing is set up, where it diffuses throughout the dressing,
Yeah.
you may want to hold up a picture of the dressing if you can, Kate, just to show where there's basically diffusion throughout that dressing. It's not just where the actual tubing goes. So you don't have to be very precise with placement of a tube.
Yeah.
But throughout the dressing, and it doesn't have to be airtight. You don't have to keep on placing tape all around the wound until there's an airtight seal.
Right. Very good point. Good point. Well, Dr. Couture, thank you so much for joining us today. And if you're watching us on live or on replay, let us know that you're here. And if you or one of your patients has an issue with a wound, whether it's a painful wound, whether it's just a chronic non-healing wound, please feel free to reach out to us. And now you have Dr. Couture's information too, so you can reach out to him.
Yeah, feel free. Thank you for having me, Kate. I appreciate it. EO2 Comps has also been very good about customer follow-up. So if we ever had anyone that has any troubleshooting issues, they're very good about getting back to a patient. So I thank EO2 for that. I also thank everyone for joining today.
Awesome. Thanks so much, Dr. Couture. And thanks for joining us. Have a great day.
Thanks. Bye, everyone.
Bye-bye.